Good afternoon, peeps. How are you? Okay, this is going to be a lecture with the PowerPoint for the beginning of Chapter 13, which is all about the lower gastrointestinal system. So this is going to include things about the small bowel series, a small bowel follow-through, the enterocolysis, and the intubation method. We start on page 488. This is just going over the correlation of where the small versus large intestine is. I know we've seen a picture like this before because chapter 12 is pretty much all about the upper portion of the alimentary canal, starting with the mouth, down through the pharynx and the esophagus into the stomach. And that's pretty much where chapter 12 leaves off. Chapter 13 takes us into the duodenum, the jejunum, all around to the ileum, through the ileocecal valve, and then we discuss further on about the cecum and the ascending colon, the right hepatic flexure, the transverse colon, the left splenic flexure, the descending colon, the sigmoid colon, the rectum, and then the anus. So we're going to start with the small bowel series. The small bowel is basically a radiographic examination of the entire small intestine. So when we look at that, sometimes they'll combine that with an upper GI series, and we'll talk about that a little bit later. But we're going to look at the entire small intestine. So that would start with the jejunum and go all the way through the ileocecal valve into the cecum. And in order to be able to see that, we have to use oral contrast media. Remember that there is at least 15 to 18 feet of small intestine. All right, when we look at the quadrant location of the small intestine, remember we have the four quadrants, the right upper, left upper, right lower, and left lower. And when they just show you the positional relationship of where everything is. So remember, we've got the duodenum, the jejunum, the ileum, and then the ileocecal valve, which is mainly in the right lower quadrant. Some of the sectional differences of the small intestine, we've said before that the duodenum is the shortest segment. It's only about 10 inches or 25 centimeters in length. Then you have the jejunum, which make up 2/5 of the small intestine, and that has like a feathery appearance or like a pillow stuffing appearance, and that's because of the little villi inside there that make it appear that way. And then the 3/5 of the rest of the small intestine is actually the ileum, spelled I-L-E-U-M. And that is actually the smallest in diameter of the three sections of the small intestine. And that picture is on page 489. When you look at the differences between the large and small intestine, the main three things are the internal diameter is different. There's haustra, which are the pouches that the large intestine is pulled into, and those are pulled into those pouches by these Taenia coli. You can see that right here. The Taenia coli are bands of the longitudinal muscles right here that run along that actually make those into little sac-like portions or little pouches in the large intestine. Okay. And then you have the relative location, meaning that the small intestine is pretty much in the center, and then the large intestine wraps around the outside of the periphery of the abdomen. Okay, and then we are going to talk about the small bowel series. Now, the small bowel series is, like we said, just an examination of the small intestine, and some of the clinical indications why a patient might have a small bowel series would be for enteritis or gastroenteritis, Meckel's diverticulum, a neoplasm, malabsorption syndrome, ileus, whether it's mechanical or adynamic or paralytic. And this picture actually shows ileus of the small bowel, which is large amounts of air. All right, let's look at regional enteritis or Crohn's disease. Okay, this is actually Crohn's disease, which when they talk about that, it's where on the radiograph, segments of the lumen are narrowed and irregular. They tend to have like a cobblestone appearance. And you can see this is actually the probably the compression paddle that's pushing down on that. But when they talk about the cobblestone appearance, kind of like some of the streets in like Italy or somewhere like that, where they're made up of little cobblestones, and that's what that appearance looks like when a patient has Crohn's disease. Then we have, I can never pronounce this word, giardiasis, where there's dilated intestine that have that thick circular folds within it. You can see here that this is very accentuated folds in the intestine. Okay, it doesn't really look normal, and basically this is an infection of the lumen of the small intestine caused by the protozoan Giardia lamblia, and it says it's spread by contaminated food and water, and it can also be spread person to person. Someone with this might have gastrointestinal discomfort, diarrhea, nausea, anorexia, and weight loss. All right, and typically a small bowel will demonstrate this as dilation of the intestines and a thickened circular folds. Sometimes they can do lab analysis of a stool specimen as well to confirm the presence of that. Ileus is where we have extended loops of small bowel, okay, and they are dilated with air. Like you can see all of this right in here are all dilated loops of the small intestine or small bowel. Extremely painful for the patient. It's an obstruction. And then typically the proximal jejunum is expanded with air. And there's actually two types of ileus. You can have adynamic or paralytic ileus and mechanical ileus. Then we have Meckel's diverticulum. Okay, Meckel's diverticulum is a birth defect caused by the persistence of the yolk sac, resulting in a sac-like outpouching of the intestinal wall. It's typically seen in the ileum of the small bowel, and most of the time this is found incidentally, meaning they just happen upon it. They're not actually looking for it. Typically, it doesn't cause any symptoms unless it gets inflamed. And it's rarely seen on any barium studies of the small bowel because of the rapid emptying of a barium study, but it's typically diagnosed with a radionuclide scan, which is a nuclear medicine study. All right, as far as the small bowel procedures, there are different procedures that are done to visualize this. We have the small bowel only series, which is usually referred to as an SBS, and that actually is on page 498. Then we have what's called an upper GI small bowel combination. It's usually called an SBFT. It stands for small bowel follow through, and that's actually on page 497. And then we'll talk about an enterocolysis, which is a double contrast study of the small bowel. That's on 498. And the intubation method, which can be either a diagnostic or a therapeutic method, and that is on page 499. Some contraindications to a patient having barium. We've talked about this before. If they have a possible obstruction, if they have a possible perforation, and if the patient is pre or post surgery within 48 hours. I recognize that says pre-surgical, but it could also be post-surgical. And remember, if they could not have the barium, then they would have the water-soluble iodinated contrast. And the only reason that they could not have that would be sometimes very young patients cannot have that. If they're severely dehydrated, they will not give them the iodine because it can further dehydrate them and impair kidney function. Or if they have a sensitivity to iodine, like they have an allergic or an anaphylactic reaction. So different things. Ideally, we would use barium, but if any of those conditions were present, then we could use the water soluble. If either of these conditions were present and we couldn't do either, they would have to find some other way to visualize the patient, whether it's CT is usually the method of choice, depending on what's going on with the patient. As far as the patient prep, typically with this, they are at NPO for at least 8 hours. That goes along with no gum chewing, no cigarette smoking, and typically they'll put them on some kind of low residue diet. Now, not saying they have a specific diet, but they'll usually warn them that, you know, they want the entire small bowel empty. So they'll tell them to just kind of watch what they eat prior. They talk about that the goal of patient prep for the small bowel is basically an empty stomach. So you typically withhold food and fluid for at least 8 hours prior to that exam, and ideally a low residue diet should be followed. Low residue meaning you don't want anything that's going to stay in there long periods of time. And as always, we ask about pregnancy if that is a potential. As far as prepping the room, it's kind of like anything else we've talked about as far as contrast study goes. You want to make sure your fluoroscopy is set up and your imaging equipment. We do need a scout for this particular exam. You would have to take a scout abdomen prior to giving the patient any contrast media. Because remember, once you give them contrast, you can't go back to having an empty abdomen. Once you know that the scout is cleared and everything's good, then you would go ahead and prep your contrast. You would make sure you have image receptors if you did not have a direct DR system. And then when we talk about the catheters, that is if we're in the intubation or the enterococcus, that would be necessary. Now, a small bowel only series. This is back on page 498. And typically with this exam, you can see here I wrote that we do a scout radiograph of the abdomen. However your patient's body habitus is, you want to include the entire abdomen for the radiologist. At that point, once that's cleared, we give the patient 16 ounces minimally of barium. And you want to make sure you note the time when the patient is done. Now, when I say that, what I mean to say is you give the patient 16 ounces of barium and they're required to drink it. They can't sip it and, you know, work on it really slowly, but at the same time, you don't want them to chug it. I usually tell patients I would give them between 2 and 3 minutes to drink all of that barium so that it tends to stay together as it travels through. 16 ounces, like I said, is a minimum. That's 2 cups of barium. And when the patient finishes the barium, you want to make note of what time it is exactly. Like, let's say this patient came in at 8 a.m. and they finished the barium at 8:30 on the dot. Once you note that time, you then have to take a 15-minute image, a 30-minute image, a 45-minute image, and a 60-minute image. And that's all based off the time they finished. So if they finished at 8:30, your first image would be at 8:45. Your 30-minute image would be at 9 a.m. Your 45 would be at 9:15. And your 60-minute image would be at 9:30. Those are, you have to take all 4 of those images. And notice you can see on there that I have the APPA, APPA. Typically, we refer to this as flip-flopped KUBs, meaning one image the patient's on their back, and then usually you flip them over so they're prone. And what this does is kind of help spread out the small intestine so that the radiologist can visualize different areas as they're looking at these images for diagnosis. After the 60-minute image, you're going to check the images. At that point, what happens if the barium has reached the ileocecal valve, then imaging is done other than having to take a spot image with the fluoro tower of the ileocecal valve. If the barium has not reached the ileocecal valve, then whoever checks that, whether it's the radiologist or the lead tech, they would tell you wait X amount of minutes and take another image. Whether, depending on where it is, they might tell you to wait 30 minutes, they might tell you to wait an hour, they might tell you to wait 2 hours. It's totally dependent on where the barium is in relation to the patient. But your small bowel study is not deemed complete until it's reached the ileocecal valve and passed through that. Okay, once it passes through the ileocecal valve, you would then image the entire small bowel, and that is acceptable. I have had a patient, just to share with you, I had a patient once that had slow motility, and we started doing the small bowel. When we got done with the 60-minute, the radiologist asked for an image in another hour. I had done that. It really hadn't moved. So the radiologist told me to let the patient go down to the cafeteria, have breakfast, have coffee, try and help move things along, and then bring them back up. When I brought him back up and did that image, it still hadn't really moved. So the doctor actually told me to let the patient go home and have him return. It ended up being like an 8-hour image. Brought the patient back, 8 hours, still hadn't reached it. So they actually took the patient home and told them to come back the following morning for a 24-hour image. And finally, at the 24-hour image, it had just barely reached the ileocecal valve. So everybody's a little different. I've seen some patients that after the 30-minute film, it's already going into the large intestine. So everybody is completely different. And again, it depends on what's going on with your patient. In this particular image, it's kind of cool. This is actually, the radiograph can be seen on, let me find this for you. Well, I thought I knew where it was. This particular image has parasitic roundworm in it. Isn't that disgusting? This parasitic roundworm, literally like a worm in a patient. And sometimes what happens is patients will actually, you've heard of people taking tapeworms and swallowing them to attempt to lose weight. This is a parasitic roundworm. All right. When we do the first image on the patient, this would be the 15-minute radiograph, which is 15 minutes after they finish their barium. Okay, so at that point, you would lay the patient either on their back or on their stomach. Honestly, I usually end up laying them on their back because that's just easier. But in this particular picture, notice she is laying on her stomach, which is fine. The central ray for this is actually 2 inches above the iliac crest and midline. Okay, and these pictures, if you're trying to look, this is actually on page 513, where it shows you a PA of the bowel. All right, so we're on a most likely a 14 by 17 or a 16 by 16 IR. You're going to leave it open to a 14 by 17. Ideally, if your patient's body habitus is such that they would fit on the 14 by 17 portrait or lengthwise, I would do that. If their body habitus was wider where they might not fit, you could actually start with one 14 by 17 landscape and see what you've got, and eventually you might have to go to take 2 images landscape to get the entire abdomen. The reason you're 2 inches above iliac crest and midline is so that you can actually capture in that first image. You want to be able to capture the stomach included so that you can see any reflux or anything that's going on with the patient. So notice that the first image is 15 minutes, central ray is 2 inches above iliac crest and midline, and then after that, you're 30, 45, and 60-minute image, and any subsequent images are all going to be the central ray at iliac crest and midline. Okay, so you can see in this first one, they're outlining her iliac crest, and they're about 2 inches above, and midline being down the spine. And then every other image, they're actually at the crest and aligned with the spine. Okay, and this is again on page 513. And typically with this, you will probably get a diaphragm on this, and the respiration for this is on exhalation, right? Because we're on abdomen, so all abdomen is on exhalation. And ideally, we want to use left marker if at all possible. Now, something I did not mention yet, which I should have, is these images are timed, okay? Anytime you have a study that is timed, it is considered a functional study. Okay, functional study, meaning you're looking not so much at anatomy, but you're looking at function of that anatomy, meaning you're trying to see how long does it take for food to go through that small intestine. All right, I'm trying to find you could actually read that. Hang on one second. Okay, if you look on page 494, under the purpose, it says the purpose of the small bowel series is to study the form and function of the 3 components of the small bowel and detect any abnormal condition. Because the study examines function, it has to be timed. All right, this isn't the only functional study. When we've talked about an IVU or an IVP, where we look at the urinary system, that is also a functional study. So anytime it's a functional study, there has to be time involved. So when we take these images, when you take this first image, somehow you would have to annotate that that was a 15-minute image. And then each of these subsequent images, you would have to annotate a 30-minute image, a 45-minute image, a 60-minute image. Whatever it happens to be, that is perfectly fine to be annotated on there. If you remember in the lab, you saw the markers hanging on the wall, and some of them had numbers. This is where you could use those numbers. If we would still use lead markers, that's acceptable, but you could also annotate, which makes it a lot easier. This is just an example of a 30-minute small bowel, and like I told you, when you put the patient PA, it separates the loops of bowel better. So in this particular image, the stomach has still got quite a bit of barium in there, and then it's coming around. You can see duodenum, and then jejunum is all over here. You can see it looks different than the rest of it, and it's actually already passed and starting to go up into the large intestine. When you look at these images, on the 30-minute, this particular picture, they're telling you that the entire small intestine is being demonstrated, and they're pointing out again that intestinal parasite, which is that parasitic roundworm. I still haven't found where that actual image is. Sorry about that. I know I've seen it in here, just for some reason it's not jumping out at me. No pun intended at this point. All right, and then at the 1 hour, they want to make sure that you recognize time markers have to be visible on there, and you want optimal exposure factors. I don't see any time markers, but again, this could be annotated with all of our digital equipment. When they go ahead at the end, when the barium has gone through the ileocecal valve, and I said that they have to take a spot image with the fluoro tower, the reason that's done is to prove that you have passed, that the barium has passed through that ileocecal valve. So on here, you can see the fluoro tower is right here. This is what comes across the patient. It's got lead drapes on here to protect the radiologist and the technologist. The Bucky slot shield should be all the way out can see it's not in here, probably because it was done just for educational purposes, but that Bucky should be all the way down if they've got the fluoro tower over. And what they have on here is called a compression cone, this right here. That actually, you can bring this whole fluoro tower down and kind of push on the patient so that you can get a better image of that ileocecal valve. Okay, and that particular picture of that spot of the ileocecal valve is, you can see a good image of that is on page 492 in figure 13.16. They point out, actually I have it, I'm so sorry. This one right here. Here's the ileocecal valve. This is the same one as on page 492. So when they get an image of that, it's showing that the barium is coming from the ileum, the terminal ileum of the small intestine, into the cecum of the large intestine. And that's an excellent picture. That's ideally what you're trying to get, and that's why you actually would need this cone to kind of push all the other intestine out of the way, so that ideally the radiologist or fluoroscopist, whoever takes that, is able to get that that image unobstructed of the ileocecal valve. You can see on this 2-hour image, they're starting to show you that the ileum is all the way over here, terminal ileum, and then it's coming up the ascending colon, going around to the transverse colon. All right, so well beyond where it needs to be at that 2-hour mark. All right, now, before we get into the enterocolitis, that is all there is for the small bowel only series. As far as the small bowel follow through, I didn't put a slide in here, but what I would tell you with that is a small bowel follow through. This is on page 497. Okay, a small bowel follow through is a complete upper GI study followed by a complete small bowel series. So what does that mean? That means that patient is with you for a long time. They're probably with you a minimum of 2 hours. All right. So in that small bowel follow through that we typically call that, you would pretty much have your patient come in and you would take that scout image, because once you start and give contrast of any kind, you're not going to be able to undo that. So you take your scout image of your patient. Once that's clear, you go ahead and stand the table up and have the radiologist come in, and the patient would take the barium in their left hand while they're standing in an erect LPO. They would drink some barium at the fluoroscopist instruction, and they would kind of do their thing as far as having the patient turn around, lay back on the table. At some point, the table lays down. The fluoroscopist would be taking images of the patient. At some point, when the fluoroscopist is done and they leave the room, we would go ahead and get our 4 overhead images of our upper GI. That would include the AP, LPO, RAO, right lateral. Then we would have those images checked and make sure that they came out. Once we were told by either the lead tech or the radiologist or whoever was over us as far as authority to point out that they were good, we would go back in the room. We would then give the patient 2 cups of barium to drink. We would note the time when the patient finished that barium, and then we would begin doing our 15-minute, 30-minute, 45-minute, and 60-minute images until all that barium, or until barium has passed through the ileocecal valve, at which point we would get the spot image. So a small bowel follow through is a complete upper GI followed by a complete small bowel series. And again, if you're trying to understand what I'm saying with that, it is on page 497 where they discuss that. An enterocolitis. Now this is a double contrast study of the small bowel. All right, this is on page 498. And some of the clinical indications, if a patient was to have this, they might be trying to rule out small bowel ileus, regional enteritis or Crohn's disease, or malabsorption syndrome. Remember, mal typically means bad, so bad absorption, meaning they're not, a lot of times with malabsorption syndrome, the patient has weight loss, they're not retaining any of the nutrients, it's hard for them to put on weight. Those would be some of the reasons that they might order an enterocolitis. And typically with this, the patient is usually very sick. It's not, most of the time if they could go through the small bowel only, they would, but usually these patients are very sick. So instead of making them drink the contrast, what we do is we place the contrast media in their small intestine through a catheter. Okay, so we inject the barium through a catheter directly into the small bowel. Now, how do we do that? Pretty much, the patient gets intubated under fluoro. They feed the catheter and a guide wire up the patient's nose, down the back of their throat, all the way down through the esophagus, through the stomach, and it is passed all the way into the duodenojejunal junction. Now, what is that? That's the area between the duodenum and the jejunum. Okay, so you go past the stomach, through that 10 inches of the duodenum into the jejunum. So you advance the catheter that far. Then you pretty much have thin barium injected into that catheter. This was the story that I told you where we were feeding the catheter and the patient's eyes started to bug out and she opened her mouth and the catheter rolled out onto the floor because it didn't go down her throat, it came through. This was what we were doing on that patient at the time. So once we got that catheter down to the duodenal junction where it should have been, then we fill up syringes full of barium and we push it through the other end of the catheter, which is coming out of the patient's nose. So you place the barium into the small intestine, you keep filling the syringes and pushing the barium in there. And then once you get the barium in there, what we do is we instill air through the catheter, either with a syringe, or they can use what's called methylcellulose. And methylcellulose typically is what they prefer because it actually sticks to the bowel and distends it or widens it. And the reason we're doing this double contrast study is to dilate the loops of small bowel, and you're able to visualize the mucosa or the lining of the small intestine better. Okay, so you put the catheter in the patient, up their nose, down the back of their throat, through the esophagus, through the stomach to the duodenojejunal junction. You push thin barium injected through the syringe, and then the radiologist will either have you inject air or methylcellulose, which gives that double contrast effect. And then not only is the radiologist going to take some fluoroscopic pictures, but we're likely to take some radiographic pictures as well. Once that's all done, they remove the intubation tube. This is an example of a PA done on the enterocolitis patient. Okay, so enterocolitis is a double contrast study of the small intestine. Not overly comfortable on the patient, but like I said, they're pretty sick to begin with. All right, the intubation procedures. These are on page 499. And as far as the intubation, there's two different methods. You have a diagnostic method or a therapeutic method. So the intubation can either be a diagnostic intubation or a therapeutic intubation. Now, if it's a therapeutic intubation, then that is done, remember therapy is done to improve the function of something. So when it's therapeutic, we're not trying to diagnose anything. We already know that the patient has either excessive gas or excessive fluids. Typically, it can be because of surgery. But what they do is they put an they intubate the patient, or they put a tube down the patient, and they can actually withdraw the gas or the air or the excess fluids out. Instead of forcing them to pass through on their own, you can actually draw that out, like just suck it out of the patient through that catheter that is in the patient. So that's a therapeutic intubation. If you look in the book on 499, it'll tell you that it's done to relieve post-operative distension. Post-operative distension, or decompresses the small bowel. Now, a diagnostic intubation is also called a small bowel enema. And what we do with this is we're actually trying to look and take images of the patient and diagnose the patient. Okay, so again, they put a tube down into the patient, and then we inject a water-soluble iodinated contrast media or thin barium through that tube. And then we take radiographs at timed intervals, just like an SBS or a small bowel series. So the diagnostic intubation is similar to the enterocolysis, except that you're not using two different contrasts. It's just the one. And instead of them drinking the barium and doing like a small bowel, you're putting the tube, you're intubating the patient, and then forcing that barium through the tube. Okay, so diagnostic intubation is called a small bowel enema. And a therapeutic intubation, you're not trying to diagnose anything, you're trying to relieve something from the actual patient themselves. All right, so those are the four things technically. We have a small bowel only series. We have a small bowel follow through, it's a combination of an upper GI and a small bowel. We have the enterocolysis method, which is the double contrast study of the small intestine. And then we have the intubation method as well, which can be either diagnostic or therapeutic. Those are all the images that we can, imaging studies we can potentially do on the small bowel. As with any kind of barium or even the water-soluble contrast, if the patient has ingested or we've placed any of that, then the post instructions will remain that the patient needs to drink 8 to 10 glasses of water in addition to what they normally drink until their stool returns to a normal color. Okay, otherwise it'll harden in the patient's intestines, and the only way it can be removed is to be surgically removed. Okay, you don't want to scare the patient, you just want them to understand that there's a reason why you're telling them to drink as much as you are, and that is only for their own benefit. Right, well, there you go. That's the end of that. So we will meet up and discuss this. Please make sure you take notes on the actual slides if you print those out. If you have any questions, feel free to write those down and I'll be happy to answer them for you. And again, this comes from chapter 13 out of your positioning book. Take care.